for taking part of your valuable time to be with us and to teach us.
Pleasure, and I'm happy to take questions after the video presentation. Okay, very good.
Okay, Imat, are you ready? Right, so maybe I can do that then. Let me see. Okay, so which one you prefer, Michael?
We'll start. Yeah, I think we'll start with the spinal cord injury guidelines, and then we'll go to the cervical myelopathy presentation.
Perfect. Okay.
Perfect. Thank you. Perfect. Hello, I'm Michael Fehlings from the University of Toronto, and it's a Hello, I'm Michael Fehlings from the University of Toronto, and it's a pleasure to be part of this spine update, which is a part of the INTS 2024 meeting here in Cambridge, and is also associated with the World Federation of Neurosurgeons. It's my pleasure to present to you the updated guidelines for the management of acute spinal cord injury, which were co-sponsored by AO Spine and the Praxis Network. I have no relevant commercial disclosures, but I do wish to acknowledge the organizers of today's course, and in particular, Nicolai, Mirza, and Francesco. Many thanks for putting this together. I also wish to acknowledge the wonderful team of collaborators that were involved in putting these guidelines together, and these are listed on this slide. And I particularly want to acknowledge my co-chair, Dr. Brian Kwan from the University of British Columbia. In 2017, we issued our initial AO Spine guideline for traumatic spinal cord injury. These were focused on the role and timing of decompression, the efficacy safety of methylprednisolone, the efficacy safety of thromboprophylaxis, the impact of baseline magnetic resonance imaging, and the type and timing of rehabilitation. Of note, these guidelines have been externally evaluated using a technique referred to as the appraisal of guidelines for research and evaluation, or the AGREE-2 instrument. And using this external validation, the 2017 guidelines were actually the highest rated guidelines in the field of spine surgery and acute spinal cord injury. But guidelines are living documents and require updating. And in the current issue of the updated guidelines, we've tackled three topics. The first is an update from the 2017 AO Spine guideline related to the role and timing of surgical decompression for acute spinal cord injury. The second topic related to the optimal hemodynamic management of acute spinal cord injury essentially builds on the 2013 AANS-CNS guidelines. And the third topic is a new topic, and this has to do with the prevention, diagnosis, and management of intraoperative spinal cord injury. These guidelines were generated using the state-of-the-art GRADE methodology, which involves the collation of scientific evidence using high-quality systematic reviews, and then this is filtered through a guidelines development group based on consensus meetings. The systematic reviews were done by an independent methodology team led by Andrea Skelly of Aggregate Analytics. And then the guidelines development consensus meetings were facilitated by Zoom to include very broad international participation, including people from multiple disciplines, as well as individuals with lived experience. And then one uses what's referred to as an evidence to decision framework to craft these guidelines. So in terms of the role and timing of surgical decompression, we were able to evaluate 21 studies. This was in contrast to 5 studies which informed the 2017 guidelines. And this is the systematic review publication in the Global Spine Journal in March of this year. This is the consort diagram. 21 studies met inclusion criteria 6 studies were included in the prior review, and there were 15 new studies. One of the key studies was one that we were involved in putting together, and this was a paper published in Lancet Neurology, which included 1,500 patients from the STASCUS, NACT, NASCUS 3, and SIGEN prospective studies. And essentially, this was a pooled data, 1,020 patients with delayed surgery and 528 with early surgical intervention. This is one of the tables from that paper highlighting that patients undergoing early surgical intervention within 24 hours after injury had on average a 4-point motor score improvement. This study and a number of other studies have informed the subsequent meta-analyses. And here I'll present the synopsis of the evidence. So here in these forest plots is outlined the recovery of 2 or more grades of surgery, or rather 2 or more grades of motor recovery with early surgical intervention. And here we see that at 6 months and a 12-month follow-up, there is a highly statistically significant improvement in the odds ratio of patients having a major degree of neurologic recovery with early surgical intervention within 24 hours. In addition, we confirmed the results of our Lancet Neurology article showing that on average there's a 4.5 improvement in motor scores, which is also statistically significant. And then importantly, there were no increased complications, no increased mortality with early surgical intervention. And in fact, there was a reduction in these complications, which just narrowly missed statistical significance. So early surgical intervention can be undertaken safely by experienced teams. So here are the recommendations, and we now have a strong recommendation based on moderate quality evidence that early surgery be offered as a preferred option for adult patients with acute spinal cord injury, regardless of level. Now, the caveat is that these patients need to be medically stable. Now, we were unable, however, to come up with clear recommendations on the role of ultra-early surgery because of small sample sizes, variable definitions in terms of what constituted ultra-early surgery, and inconsistency of the evidence. One of the lines of evidence that came out after we'd undertaken the systematic review, but which was included in our guidelines documents, was this important study from Europe called the SkyComb study by Hoffman et al. And in this study, the authors compared ultra-early surgery, less than 12 hours, versus a combination of early surgery and delayed surgery. But most patients were operated on within 24 hours. The unadjusted analysis did suggest improved recovery in the lower extremity motor scores with early surgery that just missed statistical significance. But there were significant baseline differences in the ultra-early and early-late groups, and quite a high rate of loss to follow-up. So I would say that this study points in the right direction in terms of potential role for ultra-early surgery, but further work is needed. This work by Bijan Arabi also highlights that technique is important, and the extent of decompression likely matters, as well as the timing of intervention. And an example of a surgical technique that's being explored is the work of Marius Papadopoulos, who's undertaking a randomized controlled trial to assess the role of expansile enduroplasty in traumatic spinal cord injury. So what about hemodynamic management? We recognize that this is an important principle. This is a photograph of Nathan Evenew, who is on faculty at the University of Calgary. And essentially, there was a systematic review that Nathan and others undertook, suggesting that there was very low quality evidence related to the role of MAP to support a neurologic recovery to acute traumatic spinal cord injury. So we undertook an update of this systematic review, and there were a total of 28 publications, including 1 RCT, 27 observational studies that were assessed. Now, the concept of spinal cord perfusion pressure is emerging. The idea analogous to the management of traumatic brain injury, where we need to consider the mean arterial pressure and the fecal pressures to derive a spinal cord perfusion pressure. And this is work, again, that is being assessed prospectively by Marius Papadopoulos's group. However, what is the current state of the evidence? And the long story short is that to date, the evidence is unfortunately premature. It's of a very low nature of quality. It does not really allow us to make conclusions related to the role of assessment of spinal cord perfusion pressure. Now, in terms of the mean arterial pressure, there is evidence. Again, this is of relatively low nature, and there's also relative uncertainty in terms of the best vasopressor to use. So based on this, kind of the bottom line is, according to very low quality evidence, while the effect of MAP support and neurological recovery is uncertain, and while we're unable to discern specific recommendations around spinal cord perfusion pressure, we would largely agree with the recommendations made in 2013 by the AANS and CNS, but with some modifications. And so we have broadened the MAP targets to shoot for from 85 to 90, with a more practical range of 75 to 80 at the lower end, 90 to 95 on the upper end. And we've also relaxed the requirement for 7 days of monitoring in an intensive care unit to around 3 to 7 days based on the judgment by the treating team. And the choice of vasopressor should be left to the clinician, because the evidence really is not there to say that one is better or the other. And perhaps in the Q&A period, I can discuss what our own protocols are in Toronto. And then finally is the topic of intraoperative spinal cord injury. Here are two high-risk patients, one with a complex thoracolumbar deformity, another patient with ossification of posterior longitudinal ligament and severe compression of the cervical cord. So we sought to define what improper spinal cord injury is, to delineate the frequency, risk factors for this, to try to inform clinical decision-making. We also did a detailed assessment of the potential role of intraoperative neuromonitoring to detect changes. We then tried to define through scoping review what potential management strategy for intraoperative spinal cord injury might look like. And then finally, we came up with a care pathway for this condition. We defined intraoperative spinal cord injury as a new or worsening neurologic deficit attributable to spinal cord dysfunction during spine surgery that is diagnosed intraoperatively by neurophysiologic monitoring and/or a wake-up test, or immediately post-operatively based on clinical assessment. And here in this table, based on the scoping review, we have suggested potential high-risk patients for intraoperative spinal cord injury. Now, this is by no way conclusive, and obviously this does require a judgment from the treating team, but these are some suggested diagnoses to consider. For patients with certain types of deformities, rigid thoracic curve with high deformity angular ratio is at higher risk, revision congenital deformity. Then lesions which are associated with compression of the cord, such as OPLL, certain types of fractures, including ankylosing spondylitis, certain high-risk tumors such as intramedullary tumors are thought to be at quite high risk for potential intraoperative spinal cord injury. We undertook quite a detailed meta-analysis of multimodality neuromonitoring, and essentially the combination of motor somatosensory evoked potential plus or minus EMG has a sensitivity of 91% and a specificity of 95%. So quite good from a clinical perspective. And here again, we have validated this using a random effects model. So in terms of the summary of recommendations, for the first key question of whether we would recommend intraoperative neurophysiologic monitoring for patients undergoing spine surgery deemed to be high risk, there is a recommendation, which was a strong recommendation based on a relatively low quality evidence that this be undertaken. We then essentially adapted a care pathway and protocols from Vitali's article. This relates to an intraoperative checklist for how to manage changes in intraoperative neuromonitoring. Surgical factors can be considered neurophysiologic and technical factors, and anesthetic and systemic factors. So one should, for example, take an intraoperative pause, eliminate any sources of external distraction, and then try to consider what factors were related to the changes in intraoperative neuromonitoring, perhaps reversing these, for example, decreasing and removing contraction. From the neurophysiologic perspective, important to check the status of the anesthetic agents and also to rule out any technical factors. And from anesthetic and systemic factors, assessment of the anesthetic depth, optimization of blood pressure, and then other considerations, for example, consideration of the use of intravenous steroids or other medications such as riluzole. So the second recommendation is, should we recommend that patients at high risk for intraoperative spinal cord injury be proactively identified, and that after identification of such patients, the multidisciplinary team discussions should be undertaken to manage patients, and that intraoperative protocol, including the use of intraoperative neuromonitoring, be implemented? And the answer is yes. It is recommended that such protocols be developed and applied. Now, it needs to be acknowledged that this is still a weak recommendation, largely because of the lack of high-quality prospective data. Based on this, we would propose the following AO Spine praxis care pathway, which we have published in the Global Spine Journal. This involves the initial clinical assessment, deeming if the patient is at high risk, preoperative planning, including multidisciplinary team discussions, surgical and anesthetic planning, for example, the identification and maintenance of MAP targets, intraoperative management, and then refer to the modification of the Vitali care pathway, and then postoperative management, so having a monitored bed, obtaining imaging, and so on. So this is a brief synopsis of the updated guideline for the management of acute spinal cord injury. This was published in March of 2024 in the Global Spine Journal. It is freely available as it's open access. And on that note, we'll close, and please do entertain questions.
Thank you so much, Michael. I suggest we play the second talk as well, and then we continue.
Perfect. That sounds great.
Okay, Imat,